sorry about that. I am Nefertari, Outreach and Uterine Program Coordinator at Share Cancer Support. Today, we will be talking about issues related to uterine cancer, survivorship, including the physical effects of treatment, follow-up care, recurrence, healthy best practices, and more. We are honored to have Allison Asante join us to provide a presentation on survivorship and answer questions you may have. Please submit your questions through the chat feature or raise your hand on Zoom if you would like to unmute to ask your question. Allison's presentation will be recorded, but the discussion and Q&A will not be recorded. Now I would like to introduce our speaker for the program. Allison Asante, PA. They completed their physician assistant studies at Long Island University, Brooklyn campus. They have been practicing as a PA for 12 years, with the last 8 years specializing in gynecologic oncology. While working at New York Presbyterian Columbia University, Allison was the director of survivorship care and gynecologic oncology. After moving to Northwell, Allison has continued to specialize in chemotherapy and survivorship care. Their passion is in serving typically underserved patient populations and advocating on their behalf. Allison believes patients should be active participants, in their own healthcare and encourages patient understanding of all medical conditions. Allison has been an active participant in the Society for Gynecologic Oncology, most recently serving the Diversity, Inclusion, and Health Equity Committee. Now I'd like to turn things over to you, Allison.
Hi, everybody. I'm just going to take 1 second to share my screen. And then we'll present. Okay, that looks good to everyone? Okay, great. So not to reintroduce myself, I'm Allison. I'm here today to just discuss the trials and tribulations of uterine cancer survivorship with all of you. And then I'm really looking forward to some questions and discussion after this. You know, it was a little daunting when I started to try and put this PowerPoint together because, you know, survivorship is life, right? It's the life it's not just the cancer, it's the life you have to lead and the symptoms you have to manage and everything that comes with it after. So I focused more kind of on the clinical aspects, what's more standard for most patients. And then I think the wellness aspects and different life-altering effects of cancer treatment, you know, I left a little broader, and hopefully we can get into that more with our discussion, just because I started to try and tackle it and it felt huge. So I felt better to just go into what's affecting you guys. So uterine cancer, I know this is not a group that I need to educate, but uterine cancer is our most common gynecologic cancer. It's the 4th most common cancer in women, generally speaking. And the one positive about the fact that it's common is that 83% of people are diagnosed with early stage disease. And this means that we have a lot of uterine cancer survivors in the world. For stage 1 disease, there's over a 95% survival rate. And if you include all stages, all histologies, there's still about an 83% 5-year survival rate. So lots of survivors and lots of work to do improving quality of life. So who is a cancer survivor? So, you know, I think when we think about survivorship, most people think about the time that you're in remission, the time that you've completed your treatment. But I really actually prefer the American Cancer Society's definition. And, you know, that's basically anyone who's been diagnosed with cancer. You're a survivor from the day you're diagnosed because you're living with cancer. You're surviving. So personally, I like to think about cancer survivorship as it starts with diagnosis and it continues for the rest of your life. But in terms of clinical survivorship care, you know, it changes when you're off active treatment. and you're just in surveillance. So I'm going to focus a little bit more on that. But I really think people should be empowered to think of themselves as survivors from day one. So, okay, you've completed your treatment. Your oncologist says you're done. And now you're in survivorship, you're in surveillance. Come see me in 3 months, come see me in 6 months. This, for a lot of my patients, is actually more anxiety provoking than initial diagnosis. You know, a lot of people, you're very busy when you're in treatment, whatever that treatment means for you, whether it's just surgery, whether it's chemo, whether it's radiation, whether it's everything. I think you're very busy. You have frequent interactions with your oncologist, usually once a month, if not more. You have a lot of support. This is the time everyone's there. And then we kind of look at you and we're all stepping back from you as the patient, being like, okay, go get back to life. You know, and what does that really mean? Because I think that means something different for everyone. And I just like to talk about it because I think a lot of cancer patients feel that they need to be very grateful and appreciative at this stage, that they are in remission, they are, you know, they're able to continue living. But at the same time, you know, it's normal to be very anxious. So I think I think a lot of my patients, just in my experience, tend to be very hard on themselves at this time, thinking, you know, everything should be good, I should be better. And you know, it's really, the experience of cancer is very different than that, I think, for most people. So there are kind of 4 things that we need to be doing clinically when we're seeing a patient in survivorship care. Most important, of course, is to monitor your patient for recurrence of their uterine cancer. Also, you need to screen for other primary cancers. So there are many, you know, common cancers we know how to screen for. There also are some cancers that your risk may be elevated after uterine cancer treatment. So it's important for you to be aware of that, and also for your provider to be looking out for that when they see you. Then this is the bulk of the work, in my opinion, is going to be managing any side effects you have from your cancer treatment. And then supporting general wellness and kind of healthy living after cancer. So when you look at uterine cancer, it's very, very important to screen for recurrence of the cancer at your survivorship visit. You know, I think in most of my patients' expectations, that's really what I'm doing when they come see me in survivorship. And of course, it's the most important thing. When you look at uterine cancer, you know, I'm speaking broadly. There are many different types of uterine cancer in terms of cell types, how aggressive they are, which may have different recurrence patterns. But generally speaking, when you look at all uterine cancers, depending on the study, between 70 and 100% of recurrences will happen in the first 3 years after completion of treatment. So that is why in this first time, we're monitoring you much more frequently than we are further out. Another important thing is that in most GYN cancers, this is not true, but in uterine cancer, if someone has a recurrence that's localized in one area, you can still cure them of the cancer. So that's essentially why it's so important to be doing these careful visits to make sure you're not missing anything that may be, you know, the sign of something beginning, or, you know, some tumor in a patient, because we can't miss it, because it may make the difference between curing and not curing a patient, you know. And as a healthcare provider, as a person, either way, we can't miss cancer diagnosis. So how do we look for recurrence? And really, physical exam and symptom review are the bread and butter of looking for recurrence. Just doing these 2 things will catch 80% of all uterine cancer recurrences. So that's another thing. I think patients, you know, they come in, they tell me they feel fine. I ask them a few questions. I do an exam. I tell them everything feels normal. And they're like, that's it? You don't want to draw blood work? I don't need a CAT scan? Like, how do you really know? And, these are the best ways to screen. Just when you look at the retrospective studies where they're looking at different ways we're finding recurrence, and then they look, then they look 40 years back. How have we found different people's recurrence? What are the patterns? And you actually see that these two alone are adequate for the majority of uterine cancer survivors. That being said, lab work, imaging, and pap tests as well, I should say, are sometimes utilized and have been utilized in the past. So this next slide. So when I was starting my research, I went back to kind of what I take as the I don't even know what to call it, like the standard of care document for GYN cancer survivors. There was a paper that came out from the SGO, the Society of GYN Oncology, in 2017. And they really went back through all the different types of GYN cancers and went through how people should be tested, how often they should be seen, what is evidence-based, and what maybe things we're doing that aren't really helping the patients. So this, when you ever have a question about how to look at a patient, this is the paper I go to that really concisely will summarize all of these things. That being said, take this graphic with a grain of salt, because if I had to bet, I bet a lot of you are looking at it being like, my oncologist doesn't do exactly this. And that is appropriate in a lot of ways. So I'm kind of just going to go through each different thing so we can talk about it, because things will change. Things will change a little bit depending on your stage, your risk factors, things like that. So the first thing they talk about, again, like I was saying, symptom review, physical examination. So that I hope everyone is having done at least yearly. Even if you're, years out from diagnosis, you should yearly be seeing either a gynecologist or a GYN oncologist. I think in New York, most GYN oncologists keep their patients, but I'm interested to see what everyone's experiences are when we start talking. So my routine practice does not even match this chart. And so that's why I want to be very frank about the fact that your physician's practice may not as well. So low risk histology. So those are the majority of patients who are kind of the bread and butter stage 1, grade 1 uterine cancer with a very low recurrence risk. So they say from the beginning, you can see them every 6 months. From year 1 to 2, you see them every 6 to 12 months. And then at 2 years, you go to yearly visits. I like to see patients every 3 months. And I usually wait until year 3, 4, 5, depending on the patient, to even discuss yearly visits. But, just an example where maybe I'm seeing people a little too frequently, I find extra support, extra surveillance, extra talking about other things you can do to be healthy probably isn't going to hurt, but maybe people feel otherwise. Copays can be very expensive and other things like that. High risk histology, which are going to be the people generally that had chemo or pelvic radiation. Those people should be seen every 3 months, at least through the first 2 years. Then somewhere between age 2 and 3, they often will set to every 6 months, and then continue seeing every 6 months through year 5, and then yearly. Pap test and cytology. So here they have it as not indicated. I don't know what to say. I also do not do pap tests as a way to monitor for recurrence. What they find is for a lot of women with uterine cancer, if your cancer comes back, it will come back at the top of the vaginal cuff. So when you think about that, a lot of people think, oh, a pap would be a good idea to test for cells at the top of the vaginal cuff. And it does find recurrences. But what they actually found was it didn't find, when you look at the studies, it didn't find any recurrences that weren't already found either by physical exam or someone's symptoms. What I find more commonly a few years ago when I was still doing them was you'd see a lot of slightly abnormal results. That would mean a patient had to follow up and can be very stressful as a survivor, just having an abnormal test, you know, and not knowing exactly what that means. So I don't do those. Some GYN oncologists certainly do though, so not to say that it's completely wild. So CA125, this is another slightly controversial one. Again, it says insufficient data on this graph, but when you look, 50% of all women with uterine cancer will have an elevated CA125 blood test before surgery. This blood test is really intended for ovarian cancer. It's an ovarian cancer marker. But if it's elevated in 50% of patients before surgery, the thought is of those patients, if they have a recurrence, it probably will be elevated again. So it's a pretty non-invasive way to monitor. Now, that being said, you know, I'm not like, oh, everybody should be asking for this, because I really think there's only a small population, well, the 50%, where it was elevated before. Or if you're someone who maybe had metastases or a more high-risk histology, like a serous cell type or a sarcoma, then it's more, I think it's more reasonable. I do not routinely do this in all my patients, only in the ones who basically fit into that group. It was elevated before surgery, they had metastatic disease at diagnosis, or they're a high-risk histology for recurrence. Radiographic imaging, I would say, is essentially CAT scans or PET scans. Again, so this is not indicated as a routine screening, and that may differ from a lot of your experiences. The only one that data has backed up getting CAT scans on patients without symptoms would be patients who have uterine sarcomas. And those they do recommend CAT scans every 6 to 12 months through Survivorship. But again, this is a test I think sometimes can be relevant for people, depending on your risk for recurrence. Most uterine cancer survivors are at very low risk for recurrence. But, you know, with advances in immunotherapy, especially in uterine cancer, it may be important to find disease before a patient has symptoms. You know, if you wait till someone has symptoms, that usually means they're going to have a higher volume of tumor to cause these symptoms. And when someone has more tumor volume, one, you have to manage whatever symptoms it's causing, but two, it makes us want to be a little more aggressive generally with whatever the recurrence treatment is, most of the time chemotherapy. If we find something small, it often, before you're symptomatic, it often can open hormonal or immunotherapy treatments that may work a little bit slower, but we have some time because you only have, you know, a tumor this big in a lymph node that you weren't aware of. So again, I wouldn't say for everyone, but there is a small group. So that's just kind of to give you guys the perspective that we're going through as providers, and I hope all of your oncologists are going through every survivorship visit, kind of why they're doing this, what they think your risk is for recurrence, and how that dictates what tests they send you for. So here's the big question. So what are the symptoms that you're supposed to be looking out for? If we're saying that symptoms and physical exam can find 80% of uterine cancers, you know, what should we be worrying about? And the problem is it's a long, vague list. So the first one, vaginal bleeding. That's easy as a uterine cancer survivor. Most of you went through inappropriate bleeding at diagnosis, and having that again always makes the patient call me or come back. That's, and oftentimes it's caused more by, you know, post-radiation effects, vaginal atrophy after menopause. Most of the patients I see in survivorship with vaginal bleeding don't have a recurrence, but it's an easy symptom as a survivor, I think, to know when to worry about it when you see this. The rest of the symptoms I find are a little more vague. So bowel issues, that basically mean, and bladder issues. So both those things, what I mean is a change from what's normal for you. You know, everyone's bodies are a little bit different in terms of, you know, bowel habits, bladder habits, but you know your body, you live in it. So if you notice, oh, you know, I'm super constipated all of a sudden, and this has never happened, or, you know, I used to be able to sleep all night and not have to wake up to go to the bathroom, and now I wake up 5 times to urinate. Like, what's going on? Those are things that should make you, you know, you should always note them and think that they may be related to your cancer. Other things are going to be bloating or feeling very, very full quickly. So what I mean by bloating, it's a little hard because obviously everyone feels bloated sometimes, right? What I mean is really you're not hungry, and when you start to eat, you feel full much quicker with a smaller portion size than you typically would. Some people will describe it as I weigh myself, I haven't gained weight, but my pants don't fit around the waist. You know, things like that are obviously things to note because they happen quite often, but if they hang around, those are things to call your oncologist about. Abdominal pain. So another little tough one, you know, if you're a survivor and you've had surgery, you probably have some adhesions, and you could have gas pain. You know, everyone has some pain that could be short-lived, but always think it could also be related to your cancer. Lower extremity edema, in terms of what to look for survivorship, I would say if it's sudden onset, then I would call my provider, or if it's one-sided. If you are someone who maybe at the end of the day your ankles are always a little bit swollen and that's continued, that's not something to worry about. But if all of a sudden you're noticing one leg is or both legs are very swollen, you know, for more than a day or two, it doesn't get better with rest, those are always a sign to call. And then changes in energy or appetite. So appetite we discussed a little. You know, energy, I like to compare cancer to a parasite. It takes everything it needs from us. And so if you're feeling just exhausted and you can't put your finger on it, you know, that's something to mention or even call your oncologist about. I feel like this list is a little bit daunting just because the sheer volume of side effects people could have. You know, GI changes like nausea or bloating or feeling gassy. Those are things a lot of people may feel throughout a week just based on what you ate, if you drank too much coffee, if you're dehydrated, things like that. So I always tell patients, in terms of cancer symptoms, you're looking for symptoms that are persistent and progressive. They are going to hang around. They're not going to be there one day, go away, and never come back. They're going to keep coming back. They're going to get a little bit worse in character. So my general philosophy is, you know, you all live in your bodies. You know what's normal for you. If you're having an experience or a symptom that's not normal, just try to note it, because most of the time it will not be related to recurrence. And of course, thinking about it can make you super anxious. So just note it, maybe write it down, maybe every day for a week, write down your symptoms. If you're bothered by something for more than 2 weeks, especially if it's getting more frequent or worse in nature, call your oncologist. It never hurts to call and say, I'm having this weird symptom and I'm super nervous that it could be related, you know, to my cancer being back, and what do you think? Because survivorship is a new experience and everyone has to kind of get used to how it feels for them. And especially GI symptoms when you likely have adhesions after surgery can be tough, because a lot of my patients' bowel habits can change, you know? So and chemo and radiation can also do it. So just something to be aware of, but always persistent and progressive. Don't get one little day of bloating, you know, to ruin your whole week, because, you know, obviously sometimes it's hard not to get into your head about this stuff. And then, so that's talking all about monitoring for recurrence. Most important, symptoms, physical exam. If you feel well, that's always the most reassuring thing, that your cancer is not back. Another purpose of survivorship care is to monitor you for other cancers. So that for me means making sure you're up to date with any screening test we can do. Obviously breast cancer screening, colorectal cancer screening, yearly skin exams, I think is something a lot of patients do skip, but skin cancer is very common, especially as you age over 60. And it is important if your primary care doctor doesn't do a careful skin exam annually to see a dermatologist for it. Genetic testing. So genetic testing is very important in uterine cancer survivors. The most common genetic uterine cancer is going to be caused by Lynch syndrome, which is kind of a few DNA mutations people can have that put you at risk for not just uterine cancer, but also colon cancer, breast cancer, prostate cancer, and a myriad of things. So what is standard of care in GYN oncology is if you had surgery, they do an initial test on your tumor to see if there's something that means that it could be a hereditary cancer. If that comes back positive, then your oncologist should be referring you to a genetic counselor for this testing. Another thing to think about is if your family history changes while you're seeing your oncologist, say you've had this cancer, you're 5 years out, but now 3 first cousins have been diagnosed with breast cancer or something else. That's important to tell your oncologist because genetic counseling is a dynamic field right now. It's changed a lot since I've been practicing. And it's important not to miss people because there are a lot of cancers we do know how to screen for. One I left off this list, but is a good one, is if you're a former smoker who has more than 20 years history of smoking, and the way we calculate that is however much you smoked a day, half pack, 1 pack, 2 packs, multiplied by the number of years you smoked. So if you smoke 4 packs a day for 5 years, you're still going to have a 20-year history. That increases your risk of lung cancer. And now, we have lung cancer screening with low dose chest CT scans. They specifically make it a lower dose of radiation to be more safe to get it. But in former smokers or current smokers, that's another important thing to consider. And then we also want to look for secondary cancers. So there are some cancer risks that can be changed by your treatment for your uterine cancer. And it's important that these things are discussed in your follow-up. So if almost any type of chemotherapy that a uterine cancer patient would receive has a slight increased risk in leukemia and myelodysplastic syndrome, which are 2 types of blood cancers. It is not huge. It's about 0.5% to 2% increased risk, depending on how much and what type of chemo. But it's important to know, and that's blood cancer screening. I don't want to say that drawing a complete blood count is the same as blood cancer screening because it's not, but it's a good prelim test to know if you're having normal bone marrow function. So anytime I see a patient who's had chemo for a survivorship visit, I just draw a blood count. Make sure they're not anemic, make sure across the board their blood count looks normal. And that to me is reassuring that they don't have any active leukemia or anything else like that. Another one pertinent to uterine cancer survivors is pelvic radiation does increase the risk of GI cancers. So it's kind of across the board: colon cancer, rectal cancer, anal cancer. Again, it's not a large increase in your risk. But when they one small study looked at uterine cancer survivors just generally, right? They took the same 2 types of uterine cancer survivors. One group had pelvic radiation, one group had not. And what they found was GI cancers were actually twice as common in the group that had pelvic radiation to the one that did not. So this is something to know about as a survivor. Make sure you're up to date on your colonoscopy. Make sure you're following up with your primary care doctor if you have any, persistent rectal bleeding. This is another, oncologists are doing pelvic exams with rectal exams really more to monitor for recurrence, but it's another reason to do a rectal exam during the visits to make sure you don't feel any masses, you don't see anything abnormal. In terms of brachytherapy risks, because I would say more uterine cancer patients get just brachytherapy than the full pelvic radiation. I don't have the perfect answer for you. I couldn't find any study that had looked at uterine cancer patients with brachytherapy. There were some with prostate cancer, some with bladder cancer. They found the increase was pretty minimal, but we don't know because, radiation generally has a little bit of a cancer risk. So there probably is a minimal risk, but I don't really have much science to put behind that one. So now we're at the hard part, in my opinion, which is general wellness. So this is the part of survivorship where we try and support someone having a healthy lifestyle, right? Managing any modifiable risk for other type of cancers, trying to be fulfilled, be happy. This is hard, and this is where most of survivorship happens, in my opinion. And most of it's done by you. I mean, you guys could probably tell me what it's, more what it's like trying to be generally well as a survivor than I can. So I won't lecture you guys too much on it, but I'll just put a little bit, right, since we're here to talk about it. So, I think that I like to think about survivorship and wellness as kind of putting back the pieces. My belief, and it's just my opinion, is that cancer and cancer diagnosis is a trauma, and it's a trauma to your body, and it's a trauma to your mind, and you have to kind of heal from it physically and mentally. And the goal is that as we heal from these things, we can live a better future, and we can have a more fulfilling life, whatever that means for you guys. But I think the other great part about wellness is it gives patients control. One part I hate about cancer care is I feel like I'm trying to keep my patients in control, but so much is out of your control, right? Because if it was in your control, you never would have been in this situation. And yes, there are some things you can choose, like your oncologist, if you're going to get chemo, the type of radiation, but a lot of this is just listening to other people tell you about your life and your future. And wellness and survivorship is where you kind of get to take it back and see what's important to you. So obviously it's a huge myriad of things. I think important things to focus on are a generally healthy diet, minimizing behaviors that will generally increase your risk of cancer. I would say the three biggest ones are quitting smoking if you smoke, and that, that's any tobacco, so that includes vaping as well. I would decrease alcohol intake. The American Cancer Society recommends only one alcoholic beverage a day for women as the maximum, and also maintaining a healthy weight. And then I think, spirituality, whatever that means for a person, is also really important in terms of this healing time, where priorities may have shifted, a lot may have changed while you were in treatment. And, I think a lot of people think religion when they hear about, being spiritual, but other things I have seen really help patients are going to be mindfulness, and also guided imagery I've seen have really been impactful in my patients when they're trying to, get back to whatever their life is going to be. But I will talk a little bit, just obviously we're talking about uterine cancer survivors. So these are the kind of what I personally hear most frequently in terms of things that really are hard for people to get over. Depression, anxiety, I think mental health effects of cancer probably I don't need to state to this group. It's hard, it's traumatic, it's not easy. And then everyone tells you to go back to normal, and there is no normal, you know? I also think patients with a high risk of recurrence, the stress of dealing with the unknown is really hard. And so, you know, you have to take care of your whole body. Another one is the financial toxicities of treatment. I mean, healthcare in America is very expensive. And commercial insurance, Medicare, either way, it seems from my end where I'm not doing the paying, it seems like all people do is pay copays. So, you know, I think being out of work, I think especially New York, where cost of living is high and everyone's going and working and trying to, you know, have stable housing, the financial toxicities can be really devastating. Sexual dysfunction. Sexual dysfunction is present in about 50% of uterine cancer survivors. And I find that fact super interesting, only because it's not present in all people who have had a hysterectomy. And some uterine cancer survivors have essentially the same hysterectomy as someone having a benign hysterectomy. And if you don't have radiation or other things to cause pain, why is the pain so much more prevalent in cancer survivors than generally speaking with women? Personally, I think that's because the female sexual response has a lot to do with the mind, not just physical. But it's something interesting, and there's a lot of ongoing research, and it's something I really hope we can address, and it's something I hope we can talk a little bit more detail about in our discussion. There are a million things you can do to have more comfortable and pleasurable, you know, sex, if that's something you want to do. And I think it's really important that it's something your oncologist is discussing with you. Another thing, loss of fertility. You know, whether you have kids, whether you haven't had kids, having that decision made for you can be quite traumatic. Early onset menopause and what that means in terms of hormone replacement can be a big deal. One thing I would say is in most uterine cancer survivors, hormone replacement is safe. I know we all feel like very nervous about doing it, but it's been studied. And in most situations, it is okay if you're having horrible menopausal symptoms. The other thing I would say is vaginal estrogen can be life-altering for patients who either have vaginal dryness, pain with sex, radiation changes, and almost none of the estrogen is absorbed systemically. So that's also safe, and even more safe, I would say, than an oral hormone. So always know that that's an option. Obesity, I think, is a huge one in this population, because one of the biggest risk factors for uterine cancer is obesity. And this is something that obviously has many effects in terms of health. But the biggest one I'll talk about today is losing weight decreases your chance of recurrence. So it's putting you back into control. Obviously, it improves other things. I struggle with it, so I'm not here to say that it's easy. Food is a lot more than just substance, I think. But it is something to focus on. Same with exercise. Consistent exercise has been shown to improve survival and decrease recurrence rates. So whatever activity means for you, try to be active. And these two, you know, go along with managing side effects of treatment if you have any residual peripheral neuropathy and also lymphedema. And that's all I had. So I'm going to hand it back to Nefertiri, and hopefully we'll get some questions going.